Good day, everybody. Glad you could join us. Today we have another webinar series brought to you by the Michigan chapter of Scleroderma. Today's going to be a little bit different. Today, many of you, we've talked about the effects of lungs and skins and tissue, but one of the things that we haven't really talked about in the past is the testing that it has to go along with that. So today I'd like to introduce two people that, one is my co-host of this is Michael Besser, and our esteemed colleague, Dr. Nina Ramessar. And Michael, I'll let you take it over for right now and to introduce our very distinguished colleague.
Okay, thank you, John. My name is Michael Besser. I'm a patient advocate, and I want to welcome everyone to the Scleroderma Foundation Michigan Chapter's web-based educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members seeking to obtain accurate information about scleroderma. These webinars have reached scleroderma patients and their family members from all over the world, emphasizing the importance of quality education programming for the scleroderma community. This educational program is made possible in parts from grants from the Actelion Pharmaceuticals US Incorporated and Boehringer Ingelheim and the Trico Foundation. We thank them all for their continued support. This webinar we have presenting Dr. Nina Ramessar. Dr. Ramessar is a rheumatologist who has been on the Scleroderma Foundation Michigan Chapter's Medical Advisory Board for the past 3 years. Dr. Ramessar was a support group leader in the St. Joseph, Michigan community, where she also practiced medicine and saw scleroderma patients. Dr. Ramessar assisted the Michigan chapter with website content and presented to scleroderma patients. She is well known for her compassionate nature and vast knowledge of scleroderma and autoimmune disease conditions. Dr. Ramessar is a member of the American Board of Internal Medicine. She received her degree from the University of West Indies, Trinidad. She completed both her residency in internal medicine and her fellowship in rheumatology at State University of New York, Brooklyn, New York. Dr. Ramessar is now practicing at Rutgers Health in New Brunswick, New Jersey. She is also the assistant professor at Robert Wood Johnson's Medical School, New Brunswick, New Jersey. We thank her for sharing her time and talent with the scleroderma community today. Doctor, if you'd like to go on, please. Thank you.
Thank you, Michael and John. So today I'll be doing understanding the scleroderma tests. Next, and I have no disclosures relevant to this topic. So I wanted to go over the objectives of this webinar. First, we're going to review the labs that your doctor, your rheumatologist may order and why they're needed. We're also going to review the tests that are necessary for long-term monitoring and why they need to be done. Sometimes it can be very daunting to actually continue doing these tests every year, and I'm going to explain why it's necessary. We're going to review some terms that sometimes can be somewhat confusing, and I'm going to explain why, again, some of these tests are necessary. Next. So I'm going to do a very short review of what scleroderma is. I know many of you know all of this already, but it sort of introduces some of the complications that are associated and why we need the test that I'm going to discuss. So of course, it's a rare autoimmune disease that can be devastating for some, but not for all. And that's where monitoring for complications is so important. Scleroderma, of course, is associated with skin thickening, which we are aware of, Raynaud's, esophageal dysmotility, which sounds like a mouthful, interstitial lung disease, pulmonary arterial hypertension as well. And I'm going to go through each of these so you can understand what they mean and why we do what we do. Next. So, types of scleroderma. So I'm going to just review this as well because it helps define the different types and then why we do the specific monitoring and why we ask for specific things as the months or years may go by. So there are two big types. There's localized, where you have also known as morphea or linear scleroderma. Now, these are where you have these small patches of skin involvement, and it's important to just understand that with localized involvement, you don't have internal or systemic manifestations. Now, the other type, which is generalized scleroderma or systemic, is divided into three forms. There's limited cutaneous, where the skin thickening, which is limited to the face, the neck, and below the elbows and knees. Then we have diffuse, and this one involves skin thickening essentially everywhere else as well. So you'll see the trunk as well as above the knees and above the elbows. And then we have this third very rare variant, which is called systemic sclerosis, senior scleroderma. Now, in this very strange subset, patients actually don't have skin involvement, but they have a positive scleroderma test and they have internal organ involvement. For example, like the interstitial lung disease, which is that scarring of the lung that we'll talk about a little bit later on. So I wanted to briefly go over what is the ANE test. And of course, many of you, if not all of you actually, would have had a positive ANE test. And so sometimes it can be a very confusing term, and many patients may actually feel very apprehensive or very anxious whenever they hear that they have a positive ANE. So I just wanted to review a couple of things and facts about this. So an ANE is an anti-nuclear antibody. And of course, it should be done when your doctor suspects an autoimmune disease. Now, there's certain reasons that your actual primary care, of course, your rheumatologist, after speaking to you, may decide to order this. One, you may have the presence of Raynaud's, and this is where you have color changes of the toes, fingers, nose, ears, lips. It's basically anywhere which can become involved with cold exposure. And in fact, stress can actually bring on Raynaud's. And the color changes we usually see, of course, white, turning to blue, turning to red. We often consider doing an ANE if a patient has puffy hands, if they have ulcers on the fingertips because of the Raynaud's, if they have calcium deposits, which are these chalk-like material that you can actually get at the tips of the fingers of the hand joints that can extrude. And then we have abnormal nail beds, where when you look at your actual nail beds, you see these red marks, or you may see these discolorations. This is a reason to actually do an ANE test.
Doctor, before we leave here, maybe you'll talk about it later. What is the percentage that we might get of false positives on a test like this?
That's a good question. So there are actually different values, and I actually have them here. So a positive ANE test is actually, what happens with this test, the lab runs it and it gives you what we call a titer, or an actual number. And so to be the new criteria that we have to consider someone positive, where we will ask you to get other specific antibodies for lupus, for Sjogren's, for scleroderma, it may sometimes be considered to be a number that is 1 in 80 for lupus, or for the other ones, 1 in 160. Now, that's somewhat confusing, I understand. So what happens when you go to get the test, you actually get back this number. And there are many people who actually have what we call a low titer ANE. That is, they have these very low values. Like normal people can have a positive ANE. So that's where that number is very important. For example, up to 20 to 30% of just normal people, you and I, may actually have a positive ANE, but it's 1 in 140. And so what we consider to be positive is anything above 1 in 80. And of course, you'll see as I go through a couple of my slides, you have to have symptoms with it. Just having a positive blood test doesn't mean that much. You have to have symptoms because you have to treat something, obviously, and you have to follow something. Does that make sense?
Yeah, so many times a person, if a doctor is concerned, might run this test. The person might show markers or a low number, but as years go on, the number may increase, and then at
I
that
may
point
stay
in
the
time,
same.
yeah. So okay, thank you.
No problem. And there it is. So sometimes a positive ANA alone, right, is done. And it may reveal a certain pattern as well. So I just talked about the number, but when the technologist or even when the machine actually reads, it's able to pick up certain patterns that are more specific for lupus or for scleroderma. And that's when your doctor will send you for further tests for specific antibodies for these diseases. And also, as I said before, many healthy patients can actually have a low positive ANE, and it means very little without the other signs of diseases. And what often happens, if I were to see someone with a low titer ANE, we usually see that patient maybe every year. We tell them all of the warning signs or all of the clinical symptoms or features of lupus, Sjogren's, scleroderma, and of course to notify the clinic if any of these things happen. Right? As I said before, having a positive ANE, right, may actually also mean that you do have a specific antibody. So that's why we send patients for these further tests. So let's get back now to the scleroderma antibodies. And yes, there are many. Every day we keep, well, not every day, but every couple of months, due to good science, of course, we keep detecting that there are new ones associated with the different types of scleroderma. So these are a couple that I'll go through the main ones that we more, or rather the more common ones after. But sometimes your doctor may talk to you about having a positive Anticentrum, anti-TH2, an anti-U1-RMP, an anti-PMSCL, U3-RMP, scleroderma 70, the RNA polymerase, and having just a positive ANA with a nucleolar pattern. And that's the pattern that I was talking about before. So when the technologist or the lab looks at your ANA, they're able to pick up different things, as I said before, that indicates if lupus is what we have to look for, scleroderma. This is something very specific for scleroderma, an ANA with a nuclear pattern.
Is there anything that any one of these antibodies that may indicate a certain type of scleroderma, or do you go into that a little bit later?
I do go into that a little bit later.
Okay, thank you.
So what do these tests mean? So a lot of these terms may be very overwhelming. And I think for me as a rheumatologist, I still let my patients know which antibody is present, because as we go through, you'll see there's certain things that we need every couple of months, every year. And I like to explain what the antibody is, what it's associated with, and why we need to do the test that we do. So the first one I'm going to look at is actually the Anticentrum antibody. So this one is associated with the limited scleroderma. Now remember, we had spoken about this. That's where patient has skin involvement localized to the face, to the neck, and of course below the elbow and knees. So in this particular, so this antibody, which is associated with limited scleroderma, gives you an increased chance of pulmonary artery hypertension. Now what that is, it's a condition where you have increased pressures within the vessels of the lungs. And without treatment, if you have high pressures, you can ultimately lead to right-sided heart failure, right? Which would, of course, can have devastating results. So that's why it's important to know that you have this antibody, and of course to monitor for the development of pulmonary arterial hypertension, because there are different medications for this. Now, before I move on, a lot of patients often ask me about CREST, because of course when you look up the term limited scleroderma, CREST comes up. And what that stands for is calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia, all of which, of course, sound like very confusing terms again. But that's a subset of limited scleroderma. The limited scleroderma patients tend to have just more of these things. But this is essentially this terminology, the limited, is what we use more so than just CREST, because CREST gives you these 5 signs and symptoms, but it's somewhat misleading because patients can often feel that nothing else can happen besides these 5. But knowing that you have limited means that we continue to monitor for all of these other complications. So why do rheumatologists, or rather, how do we monitor for pulmonary arterial hypertension for these high pressures? We order an echo. So we order the echo, of course, which is an ultrasound of the heart, and this determines if the echo determines that the pressures within the lungs are high, it means that you need to have further testing. Now, it is often necessary for your rheumatologist to order an echo every year. Sometimes if you have normal values on the echo, which do not show signs of pulmonary arterial hypertension, we may actually decide to do it every 2 years. Now, getting back, I will talk a little bit more about what happens if the echo values are abnormal. At the same time that your rheumatologist orders the echo, which should be every year, as I said, you should also get pulmonary function tests. And it's, of course, where you do these special series of breathing into this tube within a chamber, and it actually is able to demonstrate to us how well the lungs are actually working, and also how well the vessels are actually working. And we use the measurements from both of them, from the echo and the pulmonary function test, to decide if further testing is needed, if we need to repeat the test again in 6 months or even earlier, if you need to be referred to a pulmonologist or cardiologist, and of course, you'll see later on if you need to have a right-sided catheterization.
Now, Michael, I don't want to, pull into too much if you don't want to share, but have you had any of these tests that the doctor has just talked about?
Yes. I was originally diagnosed on August 1st with CREST of 2013 with CREST or limited sclera by a local rheumatologist. I was sent to the University of Michigan Scleroderma clinic, and they had done a lot of previous blood work, so I was re-diagnosed with diffuse. And yes, it's like cancer, and like I said, so that's been nearly 7 years. At first, I was going every 3 months, and then every 6 months. I'm down to a year, but I get a yearly echo, hallway walk, and PFTs. Yeah, yes, and that's and the blood work is still every 2 months I get. But yeah, it's all. I've had 2 right heart casts, both because I was borderline. But I have never, I'm borderline. They've watched it, so I'm flying under the radar there. But yeah, this is all very routine and very commonplace for me. Yes.
Thanks, Michael.
So, what happens if the echo or the pulmonary function tests come back as abnormal, exactly as Michael said? That's when you do a right heart cath. And this is explained by a pulmonologist or the cardiologist. Either of the 2 specialties tend to do it. It's a procedure which will determine if you're a candidate for medications that can decrease these lung vessel pressures. Now, your rheumatologist or pulmonologist can also ask you to do exactly what Michael said, the 6-minute walk test, to make sure your oxygen levels are normal and to make sure you don't need oxygen. And it's important to monitor for this long term, especially even in limited scleroderma patients, because pulmonary arterial hypertension can actually develop 10 to 20 years after it's diagnosed. So you'll see long term, we do it every year, the echo, pulmonary function test, depending on how you are, the 6-minute walk test.
I can honestly say, like Michael said, my late wife, I was a caregiver. She had the 6-minute test and these things done. But the one question that I have is that we've talked about the right heart catheterization. Why is it more important for the right side of the heart versus the left side of the heart that we're concerned about?
So because of the actual lung physiology, if you think of it, when blood enters, it enters on the right, and then it goes into the lung, and then it goes through the left. So if you have high pressures within the lung, it's actually the right side that, if you think of it as a clogged drain, then if this is clogged up, then the pressures get higher and higher and higher and damage this part, which is the right side of the heart. So that's why we do a right-sided heart cath, because what it's able to do is it's able to decipher specific pressures at different points, and the specific pressure measurements that you actually have to qualify for a lot of these medications and to define what type of pulmonary arterial hypertension. So pulmonary hypertension, which is these high pressures in the lung, there are many different types and there are many different causes, and you have to be able to decipher which cause, because you have to choose the medication appropriate for that.
Okay, thank you.
So again, we're going back to the Anticentrum antibody. So it means, of course, that, so we talked about all of the things that's usually associated, well, the main thing it's associated with, which is pulmonary arterial hypertension. If you have it, the good news is that you're less likely to progress to interstitial lung disease, which is where you have inflammation and scarring of the actual lung tissue. Now, with ILD, and you'll often hear your doctor just say ILD. With ILD, you'll have impairment of breath and, of course, function, and you may need oxygen depending on how much involvement there is. Now, one of the ways that we are able to decipher how much damage there is, of course, is by ordering a high-resolution CAT scan. So it's a CT of the chest, but it's special cuts that allow us to see each little piece to find out how much inflammation there is and how much scarring there is. And once again, if we're able to identify interstitial lung disease early on, we have good outcomes if this is treated early. So patients were like, why can't I get a chest x-ray? A chest x-ray gives you just a flash in time, and it gives you a frontal view of something, but it doesn't allow you to see how much scarring, how much inflammation there is. And that's why we do this, the high resolution CT of the chest.
I have interstitial lung disease. So I have it and I started, I was diagnosed right off the bat with that right in 2013. So they started me right on CellCept. So it has been controlled. It's in the bottom lobes of both lungs, and it stayed. It has not progressed in the 7 years. And I'm very happy for that. Yes.
So what else does this mean? So it means that you're less likely to develop scleroderma renal crisis. That again is a mouthful. So it's a kidney condition which some scleroderma patients may actually develop, to 5% of people. And it's more likely to develop in those who have diffuse skin disease. It's associated with these sudden increases in blood pressure, can actually lead to such severe kidney damage that you have to have dialysis. Now, it's very important that we monitor patients for this, because there are actually medications that can be used to actually change the outcome, to lower the blood pressure, and to actually allow for patients to get off of dialysis within a few months if we start those medications early enough. So, do you guys have any other questions about Anticentrum or what we've talked about?
Not yet. Nope.
All right, so we're going to move on.
I
Sorry.
was just going to say, what are some of the medication names that, so some of the people watching this might hear names about this. What are some of the medications that are prescribed?
Sure. It's odd that I actually included it a little bit later on in one of the other slides, but I can mention it now. Captopril or enalapril.
Okay.
So if you were to go in
Hmm.
to the hospital with severely high blood pressure, if you're a scleroderma patient, and of course there's changes in your kidney function, and there's actual version of enalapril, which is IV, that they can administer. And captopril is another relative of that drug that they also switch you across to thereafter.
Yes. And I know some scleroderma patients carry a card, like if they go to the ER, and I've also I don't have one, but I've instructed my wife, if I'm admitted to the hospital for extremely high blood pressure, they are to check my kidneys immediately because it's probably a sign I've gone into kidney failure.
That's excellent.
Yes.
Excellent point. I would actually, there's the EMR that I used, Epic, there's a way to put an FYI. So that's actually what I would put for some of my patients at the top for my scleroderma patients. And you'll see I talk a little bit more about scleroderma renal crisis for another specific reason right after.
Okay. Thank you.
So this is another big antibody that many of you may actually be told that you have. It's called anti-scleroderma 70 antibody. So why is this important? So it can be seen in both types, limited and diffuse. When it's present, it means that you're more likely to have interstitial lung disease or the ILD. So again, this is when monitoring for PFTs and a monitoring with the pulmonary function test and a high resolution CAT scan is so important. And exactly what Michael said, there are actually different medications that can slow down the progression. What he talked about was CellCept, also known as mycophenolate mofetil, MMF. There's also, so that's an oral medication. There's one that is also given either as IV or oral, cyclophosphamide. And of course, there's a new medication that's actually approved for this now, Lefev, nintedanib, and there are actually different ones that are actually in trial right now. So that's why it's so important to identify the antibodies, identify the symptoms that are present, and then to get these tests done to monitor for ILD.
And I do believe the OPEV is the actual first medication strictly for scleroderma that has been approved by the FDA.
It is.
It's not
the first one in the air. Yep, it is the first one. You're right, actually, yes.
Yeah, I don't think it's not one that has been piggybacked for another disease. It was actually the very first one. Yes.
Even though we've used CellCept and even though we've used, which is a mycophenolate, even though we've used cyclophosphamide for so many years and there's so many trials with both, you're right. OFEV is actually the first one.
It was a great milestone.
I'm gonna take that and run with it. So a lot of patients, one of the first things they always hear about OFEV, I'm just speaking right off as a physician, just exactly what you said, Michael. It took so many years to get this drug approved. One of the biggest side effects is diarrhea, and a lot of patients are put off by that. Mm-hmm. But you never know what effect a drug will have. You know, so sometimes you try and see because, again, you look how well you've done with CellCept. Yeah. You know, so we sometimes just have to give a drug a chance before just sticking to just possible side effects. Right. That's my piece about that.
And that's as an advocate, patient advocate, and with all this talk of COVID and everything going around and you just can't convince people that medication affects everybody differently. It doesn't matter what it is. I mean, even an aspirin. I found out after I was diagnosed with scleroderma, I can't take ibuprofen anymore because it sends my blood pressure high. If I have something with codeine in it, it puts me to sleep. If my wife has something with codeine in it, she goes hyperactive. Everybody is different in all their medications, so it's not a blanket thing. But medical science has to come together to find the best thing, as we know. But yeah.
So this is another antibody, anti-RNA polymerase 3 antibody. So this antibody increases your chance of developing heart disease and again, the sclerodermal renal crisis, which is that kidney complication that we had discussed. And here I mentioned the two drugs, captopril and enalapril. So this is one of the other things that I put in FYI on my charts for my scleroderma patients. Thing is that you have to be careful with the dose of prednisone that a scleroderma patient gets, and particularly one who is RNA polymerase 3 positive. If you give a patient like this more than 20 milligrams of prednisone per day, or you use protracted long doses of steroid, they can actually develop this. So that's why it's so important, because some of my patients may go in with joint symptoms. They're like, oh, well, they have an autoimmune disease. Let me give them 60 milligrams of prednisone. No, it is necessary to discuss with their rheumatologist, right, the actual symptoms, but also to just be cautious about how much prednisone you administer. Very, very important. It's very different from lupus or a rheumatoid arthritis flare. Very different. So some other tests that may be ordered. So you see, I just went into those three big ones. Those are the most common ones, which is of course Anticentrum, anti-RNA polymerase, anti-Scleroderma 70. I didn't go into others, they're less commonly noted, but they each have their own different complications, but overall we monitor for the same things. We continue to monitor for ILD, for pulmonary arterial hypertension, for all of the other secondary complications that can occur too. So these are just some other tests that your rheumatologist may decide to order. A CBC. So we do this, just as Michael said, you know, and because of the medication he is on CellCept, but also because scleroderma patients can actually have nutritional issues and malabsorption. They can also have anemia because of a specific reason. So many of you may actually have these red dots in the face, and it can actually be anywhere, actually, called telangiectasias. Now, telangiectasias can actually happen within the gut and within the stomach. And some of you may hear a term called watermelon stomach. And this happens in scleroderma patients where these red dots, which are really abnormal blood vessels, can cause small amounts of bleeding and you can get anemia. And that's why we do the CBC, at least every, you know, it depends on if you're on other associated medications, but at least every 3 months. A comprehensive panel. Of course, a comp gives you kidney function, also gives you liver function. Why do we do these? Obviously, kidney function, because you need to monitor scleroderma renal crisis. We monitor for nutritional issues too. You always want to make sure that your electrolytes are normal. We monitor for low albumin and low protein as well as part of that nutritional status as well. Next. So depending on how a patient's nutritional status is affected, of course, we add on different things. So besides your usual CBC and comp, you can get a folic acid, vitamin B6, B12, or vitamin D levels, right? So we often add these on when patients have, when they have bloating, or they have abdominal pain, or they have recurrent gut issues. It means that they're more susceptible to not being able to absorb, of course, these minerals. And that's where we monitor the levels and supplement accordingly. A serum uric acid. Now, yes, everybody knows that uric acid is what we use in gout for monitoring, but in some scleroderma patients, we actually use it because it can actually predict if there's any heart failure and if you need a right heart cath. So you'll see big institutions, exactly like University of Michigan, they usually do monitor this in their panel of labs. There's also, sorry.
I was just going to ask you a question on that. So when you're monitoring it, is your uric acid is showing a higher level going from lower to higher, or is it vice versa, or what?
It increases.
Okay.
And it's used in actually what is the word I would use? It's used in a specific measurement algorithm called detect, and we use the uric acid with echo measurements, pulmonary function measurements, all of them together to decide whether or not you're at high risk for developing pulmonary arterial hypertension and if you should get the right-sided heart cath.
So it's another tool in the toolbox for that you're able to use.
Mm-hmm.
Okay.
And it's used with, it's what we also measure the BNP or this N-terminal proBNP. What this is, it's a protein that is actually produced by the heart, and it's also used in that whole algorithm for monitoring. Not everybody does it. I have to admit that in my stable patients, I may not do it. But at the biggest centers where you actually do have sometimes sicker patients or patients in trials, you'll see that this is monitored on a much more regular basis. So, other procedures, you may be asked to get an upper endoscopy. And of course, this is if you have anemia, to look for that watermelon stomach. And also, one of the things that happens, and we talked about this actually, and I bring it up here, patients who can develop GERD or heartburn. And one of the reasons is that the esophagus itself, that can actually become, just like how your skin gets that smooth tapered appearance, the esophagus can also get that as well. And so that's why you may have acid reflux and heartburn occur. And there's medications that we need long-term to actually help with these symptoms.
No,
And it's also,
go ahead. I'm sorry.
it's one of the other things that you would also do the up endoscopy for, to monitor that as well.
Now I know in my wife's case is that they did that is there also is a concern of basically cancer if goes untreated, correct?
Yes, something called Barrett's esophagus can happen where the cells change. If you think of it, you have your esophagus keeps being exposed to these high levels of acid, and the cells can actually change character, and you can actually decipher a precancerous phase before actually esophageal cancer, and that's where the importance of the endoscopy comes in.
And that's one of the reasons, that was one of my, I think the first pre-symptom that I had to my issues was GERD, and then it went to Raynaud's. But they did, I was actually having a routine colonoscopy, and the surgeon that did it, who has done my old colonoscopies, he said, I noticed you're allergic to Prevacid. And it was what I had been given for my GERD, but it turned out I wasn't allergic to Prevacid. It was at the same time I started taking it, the symptoms for Raynaud's was coming out. So they thought it was that, but I did have Barrett's esophagus. But I've also found out too, in my studies, is that I have it a lot worse because I don't have a gallbladder. And I've seen that with patients with scleroderma that don't have a gallbladder because they don't have the enzyme in the gallbladder to dissolve the bile that the liver's creating. So that is also backing up in our throats and aspirating that. And like I tell anybody, if an aspiration where you're drinking a soda or a pop, a carbonated beverage, and you accidentally inhale it, how that burns, you can only imagine what bile or stomach acids do. It's like battery acid when you wake up coughing that, and you can only imagine the scarring that does to your body. Yes, it's not fun, but I don't do that anymore. Thank goodness. So
thank goodness. One of the things that we always advise patients too is you may not even realize that it's happening, and that aspiration that you talked about, especially at night. So often we ask patients to elevate the bed. It's not just about putting a pillow, because the pillow may actually cause an angle and worsen it actually. It's about elevating the entire bed so that you have time for for digestion to occur and passage. So, sorry, I'll just go back for one quick second. So you'll see, the thing about scleroderma is that it's a very complex disease. And yes, exactly what Michael said, sometimes your rheumatologist will have to refer you to a pulmonologist, to a cardiologist, to a gastroenterologist, even a nutritionist, because all of these things happen. And it may just be one time that you have to go just for an endoscopy, make sure everything's fine. And again, endoscopy, you may have to do it again in 1 or 2 years, or even 3 years, depending on what they see. But it does require a multidisciplinary approach. And that is one of the things you just have to understand about this disease. Next. And just to conclude, I want to just remind patients that this is, and you are the best judge and you understand this more than I ever will. It's a very, very complex disease, exceedingly so. It's honestly the most complex one I think that we have. And every day we learn a little bit more about it. And sometimes it's very overwhelming when you first hear the diagnosis, when you hear every little thing that you have to monitor as the years go by. So it's very easy to feel that overwhelmed feeling. Just, take notes. There may be, there's a lot to discuss usually. A scleroderma visit is, I think, one of the longest ones. Sometimes you take notes. If you have questions, go back, ask your rheumatologist thereafter. Knowledge is power. Sometimes you may have to have a next follow-up because after you get all of these tests, you have to go back and just review everything. It's a continuous dialogue. So don't feel overwhelmed, as I said, by all of this. Just keep asking questions, and that's the best way to get answers and to feel more secure about the disease, about what you're doing for it, and that both you and your doctor are actually doing everything that you can for your condition.
So let me just say, as a former caregiver, 2 things. One is, like you said, it can be overwhelming, and you have to be your own advocate. The patient and your caregiver, you have to be your own advocate and understand. And this is an excellent presentation to make you understand what are the tests that are being that they're requesting and why they're requesting it, and you can interact with your doctor. The other thing is, what I always tell patients and along caregivers, always take someone with you. When we hear all negative news, whether it's scleroderma or anything else, our brain clicks off. And basically, if you hear something that the doctor says that isn't good, is that you don't hear the next 5 sentences that he's talking about. And that other set of ears is something that's important for you to have there when you're having that time with the doctor. And also, whether it's the patient or the caregiver, we'll have that follow-up question that might help you as the patient to be able to understand a little bit more about what they're seeing and what is progression, and what you thought might have been something bad with something, okay, it's trending in the wrong direction, but it is still not at a critical point yet. So that's why I always, say to people, make sure you take someone with you.
Agreed.
And another point I'm going to add, and this is only for an experience that just happened a week ago. Like I said, my father had surgery. He ended up having to be hospitalized in a local hospital, but he was then transferred to a cardiac care unit an hour away. With COVID and everybody wearing masks, including everybody in the hospital, doctors, nurses. I saw this at our local hospital, and I saw it in Midland. Because of the mask we are wearing, people do not talk clearly. They don't enunciate. They mumble. They don't speak loudly, or they have accents. I saw and witnessed so much miscommunication. So it is very important to speak clearly. And if you don't understand, I have very good hearing, and the nurse that was taking care of my dad in ICCU had his clipboard over his name tag. And I have good hearing, and his name was Kyle, and it took 5 times for him to say it so I could understand it. So, it's important right now, especially if you're visiting any doctor for any reason, to take notes, to listen carefully. Don't be afraid to ask the questions, because I saw nurses, CNAs that didn't understand or hear the doctor's orders clearly, and then they didn't do what was told. Because apparently some nurses don't like to say, "What did you say?" So, that's just a point of observation of what's going on right now. So it's very, very important to understand completely.
So, Doctor, I want to say thank you very much for presenting today. Very educational. I know, like I mentioned earlier, many people have learned about what the scleroderma is, but really have never really understood what the tests were or what was the reason behind that. So I say thank you again. And Michael, I'll let you wrap this thing, wrap it up for us today, and with your words.
Okay. Once again, thank you so much, Dr. Ramessar, presenting today for the Scleroderma Foundation. I know this information has been beneficial for all of us. It's a good refresher for me, and I always learn every time I do one of these. So what a wealth of information you've provided us today. So thanks for this great topic. And I want to thank all of you viewing this webinar. Staying educated about scleroderma is so important. That is the reason that the Michigan chapter strategically has created web-based educational experiences. Being educated can help the scleroderma community become more healthcare advocates. I hope you'll join us for the remaining 2020 webinars and for the 2021 webinars. For more information, check out our website, which is all small letters, scleroderma.org/Michigan, or the National Scleroderma Foundation weekly e-letter that is delivered to your email every Friday. Thank you again for sharing your time on this webinar, and have a great day.